So I have the pleasure to introduce our final speaker, Dr. Natasha Lale. She is a professor at the University of Toronto, and she's going to be talking to us about competing risks of recurrence versus toxicity in non-small cell lung cancer.
Great. Well, thank you so much. It's a real treat to be here. I'm not going to tell you how old I am, but if you guessed that I was older than Dr. Antonoff and Dr. Snow put together, you might be close. So I, too, am going to bring up my computer and talk a little bit. So if we could just, oh, wait, here we go. Those are my slides. Great. I'm really thrilled to be here. I'm not sure what I did to piss off Norman and John to get the last talk of the day and talk about competing risks of therapy, but I'm really sorry I won't do it again. Still very thrilled to be here. It's been really great to see this precision approach move from late stage to early stage. Now, you guys need medical oncologists for just about everything that you do, particularly in non-metastatic lung cancers. You can see in those green boxes. We've only left you about 30% of early stage disease without us, and I assure you, we are coming soon. It's also really important that we bring all of our precision approach, the genotyping, the thought, the discussion, and I know that the group here in Montreal has really led the way in this, but it's important for all of us to follow. So at first I wasn't sure what you guys wanted me to talk about, so I thought, well, they don't really want me to talk about surgery first or systemic therapy first, right? Because that would be hugely boring, and we'd all much rather go to cocktail soon, so I think the scale would be a bit like that. But I do think that patient preference is also very important in addition to all of the data. And of course, there will always be patients who would prefer to have that tumor out as fast as possible. And I think we can't deny them the option for that. We know that surgery first is great. It's not 100% great. It's 95% great for our zero resection. We know that only 2/3 of patients get to adjuvant chemotherapy. And one of the things that I loved about the Empower 010 study, a real treat to have Dr. Wakely and colleagues with us here today, is that they really showed us the attrition. You lose over 20% during the chemotherapy phase. A number of patients recurred during that phase, so chemotherapy is not perfect. And then when we move on to the adjuvant therapy phase, with, of course, 2 adjuvant trials that you're very familiar with, Canadian one hopefully coming very soon, anywhere from 1/3 to half of patients can't complete the year. That's not actually a big surprise. And also about 20% of those are for toxicity, but about 12% of those are for recurrence. So even chemotherapy and immunotherapy is not all that in the preventive setting. And when we look at how systemic therapy protects patients, not so much for local recurrence, we've got our surgeons and our rad-oncs for that, but really, as you can see in that pink bar, it's systemic therapy. And this is true whether it's targeted therapy or whether it's checkpoint inhibition. So that's somewhat reassuring and very helpful that we bring to the table. So there's been a lot of progress for oncogene-addicted lung cancers. You guys have heard a lot about ADAURA, better PFS, better CNS progression-free survival or disease-free survival, better overall survival. And only about 13% of patients stop treatment, which is actually the same number as in the advanced stage setting. So very, very well tolerated. And almost all patients got all 3 years when they looked at median duration of exposure. Very nice data now published and approved in the US from Alina looking at our ALK-driven lung cancer patients, where again, very nice hazard ratios for disease-free survival, CNS disease-free survival. We'll see overall survival in time. And if anything, this was compared to chemotherapy, only about 5% of patients stopped targeted therapy. A challenge, of course, is should patients not get chemotherapy? This is a cancer where patients live a long time on targeted therapy, and are we going to regret this in 5 to 10 years? And so I think that's something that your systemic therapy colleagues, for all of the surgeons and rad-oncs, are still working out. Great data 2 weeks ago now. It feels like longer, but it's certainly in patients with locally advanced disease and EGFR mutant lung cancer, no longer the Pacific study, but now we give osimertinib, amazing progression-free survival benefit, hazard ratio of less than 0.2, already a clear signal that we prevent CNS progression. And if you look at that curve in the bottom left there, our patients that just get chemoradiation for EGFR-addicted lung cancer really do very badly. These patients really already have stage 4 disease, which was nicely highlighted by Alicia Sequist, and so, so important to step in early. Overall survival, we haven't seen yet, but perhaps we will soon. And again, the same number of patients discontinuing, over half, though, needing to take breaks or have dose reductions because of that proximity of radiotherapy, almost half of patients getting some form of lung injury over time. And so again, Is this the best way to treat our patients with stage 3 disease? Should we be paying a little bit more attention to how to give, whether it's chemo and TKI up front, maybe resect more patients, convert more to a potentially surgical option, or at least decrease radiation fields? I think this is the next area that we have to work very hard on, and there are a number of studies already underway. So you guys know lots about this. Only 10% of patients discontinue Checkmate 816 for toxicity. Less than 20% don't have an R0 resection. You know this already. And again, just as we saw in the adjuvant setting, we really do help decrease the risk of distant metastasis, shown in the middle bar. So who doesn't go to surgery? Mostly it's for progression, and I think we saw some nice data from Tina this morning as well, confirmatory data from 77T. But of course, even though Dr. Antonov tells us to let it go, it's actually still something that patients talk to their medical oncologists about. Are you worried that I'm not going to be able to complete all this and have my surgery? Because don't you know, doctor, I only agreed to this because the surgeon sent me here. So I think it's really, really important that we really understand who does and who doesn't make it to that R0 resection. And I think what's great is that, especially with real-world experience, I was talking to Jason Agolnik, probably fewer patients now don't make it to an R0 resection. But of course, I think that's a testament to the outstanding expertise and leadership in this room from the teams in Montreal. So, when you look at all of the other data, most patients do get through pre-op chemo IO. Only a small number, less than 15%, stop for adverse events. Again, less than 20% in the trials don't have R0 resection, and we're probably improving on that. And these numbers are the same, whether it's Checkmate 671, whether it's Aegean, about 2/3 of patients beginning that post-operative phase, or whether it's 77T, as Dr. Cassoni has now published also in the New England Journal. Very, very consistent numbers across the board, which I'm just going to flip through because you know these and you really want to have that cocktail. Now, what about financial toxicity? I used to work on this in a previous life, and these are just drug acquisition costs. These don't account for time in chemo daycare, the type 1 diabetes that Stephanie talked about, time in hospitals, all of the infliximab that we give these days. It doesn't account for any of that. But gosh, look at these prices. Medora, $400,000. Alina, $300,000. Laura, more than $400,000. Empower 010, over $100,000. Checkmate 816, winning by a landslide, $21,000. And all of the preoperative regimens, about $150,000. I've put NLAL, the Bank of NLAL costs up there for Keynote 671, but none of the other drug manufacturers are doing any better in terms of costing. And so on the one hand, you pay what you have to pay for cure. On the other hand, if we skipped 10 patients that weren't going to benefit with perioperative chemo IO, you could buy a robot for your surgeon. So I'm just saying, the more care we take, the more robots we can make. And I think it's especially important, perhaps not so much in stage 2. These aren't really patients where there's a big concern or a big risk, but especially in those PD-L1 negative patients. John tells us at every meeting it's so important to pick those patients that are going to respond. Those are the patients that will do well, that we need to treat. And so I really think we need to sort of take a moment of caution, make sure we build up our databases, and have a moment to reflect at our own tumor boards about who's going to make it and where we're just faking it. So ctDNA clearance, also gave an awesome talk earlier this morning about potential ways forward for ctDNA, but maybe we're looking at it backwards. And maybe it's not so much about clearance and who doesn't need surgery and who has a PathCR, but about who doesn't. Saw some great data from Mark Awad earlier this year at ELCC, again from 77T, suggesting that if you only got 2 or 3 cycles, maybe you did just as well as patients who got 4 cycles, and maybe that's true for patients who don't clear their ctDNA as well. Maybe if you don't clear by cycle 1 or cycle 2, just as in breast cancer, that's a signal to save your money and move straight to the OR, and then perhaps intensification later or intensified preoperative trials. I also think the other challenge, of course, or potential toxicity is genotyping and delays. Some centers have that all worked out, for example, here in Montreal. In other centers, it's still a real headache. We don't do it well in advanced disease, and we're not rocking it in early stage either. And so I think we really need to improve things. Also for our patients getting locally advanced treatment with chemoradiation, really important to know what genotype patients have, make sure we get the right samples fast enough, and have the right communication set up. Sometimes moving closer to the tumor can make things faster. We're looking at that, as are a number of other groups. MD Anderson's done a lot of work here, but maybe sometimes liquid biopsy beyond plasma ctDNA can help us as well. And so I thought I'd finish with this rather old concept. 31 years ago, Rich Gelber and colleagues from the Dana-Farber published something in breast cancer called Time Without Intervening Symptoms of Cancer or Toxicity of Treatment. And they looked at a short course breast cancer treatment versus very long course breast cancer treatment. I can't remember if it was like CMF3 versus CMF 103, but what they showed was that you really can express in patient terms how long you're going to have toxicity versus benefit, and this is a potential way to explain things to our patients. And so we actually did this in lung cancer. This is showing my age. I did this a long time ago when I used to have spare time with Raymond Zhang, who's now our program director, and Qiyu Ding and the team at CCTG. And what you may or may not be able to see is, of course, here with just observation after surgery, this is from the JBR10 trial, this is bad space, made less by adjuvant or preoperative therapy. In here, sorry, Anna, I got your head there. Sorry, man. This is time without toxicity or treatment, and here time with relapse. And so clearly, adjuvant chemotherapy improves that. Preoperative therapy or the addition of immunotherapy or targeted therapy, I think, really pulls those curves up and decreases that time with relapse even more. And so even though it probably does increase time with toxicity, it's probably still absolutely worth it to include systemic therapy in almost every case of patients with early stage lung cancer. And so with that in 2024, I think we're hitting all of the high points. I think systemic therapy is an important part of the cure. But I do think that making the journey better, perhaps even making the journey more affordable, are things we need to start working on now. And with that, I really want to shout out the amazing work from some of the great Canadians in the room, especially the teams here in Montreal. And thanks again for having me come.